Very much, Kirsty. Hello, everybody. It's a pleasure to be with you here this evening. I'll start with a quick introduction of myself and of my colleague Dimitri, and then we can open up into the presentation this evening. Like I say, my name's Ian Wood. I'm a GP down in Buckinghamshire. I'm also medical director for a company called Big Health, who make a treatment called Sleepio, which speaks to why we're here this evening. I'm also one of the past first five chairs for the RCGP and still a member of my faculty on faculty board locally too. Dimitri?
Hi, everybody. Lovely to be here. Thanks for having us. I'm Dimitri Gavriloff. I'm a clinical psychologist by training, but a sleep medicine specialist. I live and work in Oxford, down south, but I have a role that's split between work for the University of Oxford, where I lecture in sleep medicine and support clinical trials in sleep medicine interventions, really, and a role in the NHS where I run a non-respiratory sleep disorder service, which I always find interesting. We have to define ourselves in the negative, but we are not non-respiratory service. And I have a small private practice through which I do some consulting for Big Health. So I'm a sleep medicine consultant for Big Health. Great to be here.
Thanks, Dimitri. I need one to start putting up the slides, but
Yeah.
it's very apt that we're here this evening. Tomorrow is, for most of you who will know, is World Sleep Day. Interestingly, I found out this morning as well, there's also going to be a blood moon in the morning, which feels like a very ethereal thing to combine World Sleep Day with a blood moon. But if you're up early first thing, I think particularly in Scotland, you'll be able to see it better than we can in England. Why are we here talking about sleep and insomnia? Well, insomnia, it's an incredibly common condition. In fact, it's the most common mental health condition we have. Yet despite this, it's not something that in general practice and in medical school we have very much training or exposure to. Yet we are seeing patients all the time, but we are seeing patients all the time with the consequences of it as well. It affects people's mental health directly. It affects people's physical health significantly, their social well-being, their workplace productivity, their overall mental state, irritability, their ability to function. Not that alone, it also has incredibly high comorbidity rates of conditions we're very used to seeing and managing all the time: depression, obstructive sleep apnea, and beyond. And so it's incredibly frustrating that we don't really ever get the time and devotion in our training looking at the science of sleep medicine and how we can offer support to our patients in this space. Clinically in the room, sadly, too often it's often a clinical afterthought, one of those hand on the door conversations as patients are just leaving, having spent 10 plus minutes with us. They will turn to us and say, by the way, I'm not sleeping very well. Often saying, the words, can I have some sleeping tablets? It can make our hearts sink. And why have we not been having that conversation enough? Well, I think it's really because up until now, we've clinically been, if I'm honest, quite dissatisfied with the somewhat unpalatable options that we have to support patients. And I hope that by the end of today's session, we can empower you to have those conversations with your patients and talk about the treatments that we know now are effective and recommended. I'm going to start with handing over to you, Dimitri, to talk us through sleep.
Thanks, Ian. So this is I don't know if you can, I hope you can see the slides, but we're going to start working through things in a kind of sequential way. So we'll start with a bit of an introduction to sleep and sleep medicine and insomnia. We'll then talk about CBTI, which is cognitive behavioral therapy for insomnia, the first-line treatment in international national guidelines. And then we'll talk a bit about Sleepio, which is the CBTI intervention that Big Health provide and is available in Scotland free to all Scottish residents. And we have a bit of time for Q&A. So do come up with questions as you go. Very happy to answer them at the end. But we'll start with sleep and sleep medicine. So it goes without saying, as Ian was saying, I think there was a study done by a colleague of mine, Greg Storrs, who did it back in what was it, 1998, I think it was published, where he looked at the amount of time that was spent in medical degrees on sleep medicine. And I think in 1998, the average time, I think preclinical training was something like 5 minutes. And I think even in terms of kind of specialist training, it was still very low numbers. It hasn't changed much in the last 20 years, 20 plus years, but it's something that's clearly something of relevance to every patient that we see. It's something that everyone either does or doesn't do, and it's something that will, or as they prefer, and it's something that will have an effect. So when we think about the uh, the role of sleep, the way I think about sleep is I typically talk about it through the medium of a car advert. So I'll say sleep is fitted as standard, right? It's not an optional extra. It's not something that we bolt on. We need it, and we need it to function properly. So if we think about the way in which uh, sleep is something that's sort of central to our day-to-day function, and the way in which we can sort of feel it's not going to working for us, you've got all those uh, signs on the right hand side. So emotional reactivity might be off. Mood regulation, of course, is affected by sleep. Learning and memory consolidation is something that's again something for which sleep is crucial. Being able to manage attentional focus is again something that's improved with sleep and impaired by insufficient sleep. Lymphatic cleaning, so the clearance of metabolic detritus across the sleep period, is something that happens uh, um, uh, in sleep, and if it's not happening, can't happen. Um, Creativity is stifled when there's not insufficient sleep. Executive function, decision making is stifled. So there are lots of ways in which it can be impaired, or function can be impaired. And of course, sleep is central to the optimal function of all these systems on the left, from the cardiovascular system down to the reproductive system. So sleep is not an optional extra. It's fitted as standard. And these are a couple of quotes I love from colleagues in the sleep medicine field. And my colleague in the States, Michael Grandner, says, what's the function of sleep? It's like asking, what's the function of being awake? There's no one function, right? And at the end of the day, our biology requires both. And the same is kind of true with this lovely, it's an old quote, but I love it, from Alan Rechtschaffen, who was, again, a sleep scientist, august sleep scientist. If sleep doesn't serve an absolutely vital function, then it's the greatest mistake the evolutionary process has ever made. Because, of course, when we're asleep, we're vulnerable to predation. We don't do very much. We're unproductive. So it's got to be something that serves a really crucial role. When we think about what sleep looks like this. So this is a kind of a simplified hypnogram, or a diagram of sleep, sleep in sort of visual form. And you have here on the y-axis the stages of sleep, so wakefulness, uh, light sleep, transitional sleep, stage 1, stage 2, non-REM sleep is kind of a little bit more, it's much more prevalent throughout the night, about 50% of the night, sort of what we might call medium sleep. And then you have deep sleep, or stage 3, slow wave sleep. And this is a typical adult of, let's say, working age. So of course, sleep architecture changes throughout the life, but lifespan. But this is what you might expect to see. And of course, you have REM sleep in the pink there too. So across the night, we go down into deep sleep, up into light sleep again, bit of REM, down into deep sleep, up into light sleep. These sleep cycles lasting between sort of 90 and 120 minutes in adults, much shorter in small children, so maybe 50 minutes. But children at school age are already kind of moving into the adult structure. And what we're doing is we're seeing lots of deep sleep at the beginning of the night, lots of lighter sleep towards the end of the night, lots of REM sleep building towards the end of the night, when dreaming is taking place, narrative dreaming is taking place, emotion processing taking place. But the key I'm trying to sort of show here is it's a very dynamic process. And of course, we have progressively higher arousal thresholds as we get down into deeper sleep. Brain activity is increasingly synchronous, slow wave sleeps. You have this slow oscillations that are characteristic of that stage of sleep, and much lighter, fast activity as you get up towards lighter stages of sleep. And we have these brief nocturnal awakenings that take place typically, probably a spontaneous arousal, or something that happens after you cycle through a stage of sleep, bit of REM, perhaps a little arousal. These are normal. We all do them many times throughout the night. They're not a symptom of insomnia. Waking like this 5, 6 times a night briefly, going back to sleep, finding the cold side of the pillow as I do, and then going back to sleep again. That's absolutely normal and expected. So when people talk about it, one of the things we can do is we can reassure them that's expected, that's normal. We all do that. That's not a sign of a problem. But where people are awake for longer periods of time, or if these arousals are happening much more frequently and are symptomatic as kind of more fragmented sleep, this might be something that requires further investigation. So how does sleep work, I hear you asking? Well, I'm glad you asked. There is a diagram here that shows the two-process model of sleep. So you have on the y-axis here what we call homeostatic sleep pressure in the sleep medicine jargon, but in English we call it sleepiness. And then on the x-axis we have the 24-hour period. So you can see that this is 6 o'clock in the morning. If I put a laser pointer on there, we go. 6 o'clock in the morning on the left-hand side, and you have on the right-hand side 6 o'clock in the morning the following day. And you can see that roughly 2/3, again, it's an adult, 2/3 of the day, or the waking of the 24-hour day, is spent in wake, and about a third is spent in sleep. And as we go through the day, we get more and more sleepy. So the first process we're describing is the most obvious one, which is that the longer you stay awake, the more sleepy you become, the more you accumulate sleepiness. And that's represented really by the accrual of things like adenosine, the metabolic byproduct that is a sort of a sort of a biomarker for sleepiness. And then once you're asleep, that sleep pressure dissipates across the sleep period, so, assuming you get sufficient time for sleep. When you wake the next day, you feel refreshed, you've had enough time for sleep, and you can start rebuilding that sleep pressure across the period of wake. And that's a bit like pressure in a system. If you have pressure building in a gas canister, you open the valve, you release the pressure, pressure equalizes, and then it builds again when you close the valve. So this is a kind of sort of similar process, but it's a bit of a movable feast. And if you happen to have a shorter night's sleep for whatever reason, then you have residual sleep pressure that bolts onto the next day. And that's why you might feel this sort of what we call a sleep debt the following day. The second process is one that's a little bit less intuitive, and that's done as your circadian rhythm. And here we're talking specifically about circadian mediated alertness. So what that really refers to here is, well, the circadian rhythm refers to, circadian rhythms in general, refer to oscillations in all kinds of different physiological functions, physiological domains that are happening across the 24-hour period, typically have a pattern that will be a sort of a waxing and a waning pattern. And here we're talking about an increase in alertness that peaks towards the end of the waking period. So you get a subjective feeling of being most alert, probably at around 11 o'clock if you're a sort of a fairly middle of the road chronotype, someone who gets up and goes to sleep in a sort of this sort of fashion. If you're a very early bird, it might be earlier. If you're a very late type, a night owl, it might be later. But this peak might happen because alerting signal is building, it's offsetting sleep pressure. And because you haven't got much sleep pressure at that time of the day, it's creating the feeling of being alert and optimally functioning. As you get towards the end of the day, like now, what time we are now? Quarter to 8, I'm starting to feel tired. It's the end of a long day. The sun's gone down. My physiology is getting ready for hunkering down and going to sleep. And my alerting signal soon enough will start to drop off. And what that'll do is it'll expose the sleep pressure that I've built throughout the day, which leaves me feeling sleepy, which is why I start yawning and I start rubbing my eyes because the sleep pressure is becoming more obvious. Across the rest of the night, you notice that actually the circadian signal is very, very low. And about 2 hours perhaps before you would wake naturally, you have the core temperature minimum, where you have this interesting transition between the kind of the alerting signal kind of waning and then building again in preparation for the next day. So these two processes work together. And when they're synced, it works nicely. When they're out of sync, we get problems like jet lag and circadian misalignment. One of the things that I should say about this, and I haven't put it in here, is that there's something that can very easily mask this, and that is autonomic arousal. So if we think about things from an evolutionary perspective, it's very, very sensible that we can evolutionarily defer this process in the presence of stress. If there's a danger present, if there's a saber-toothed cat, lion, tiger, something scary, we don't fall asleep. We don't want to get eaten. And so evolution has allowed us to defer sleepiness in the presence of threat, which is great, keeps us alive. But of course, we don't often come across saber-toothed cats, lions and tigers in Britain these days. And so what we come up against instead for many people is the threat of whether or not they're going to be able to get to sleep, or the prospect of another sleepless night, or the the thought about going through the next day feeling absolutely exhausted. These are all things that represent internal threats in a similar sort of way, subjective threats, that can then mask sleepiness in the same way as an objective threat might. So I'm going to talk briefly through the landscape of sleep medicine. So this is our diagnostic manual, the ICSD-3, the International Classification of Sleep Disorders, and it sort of maps sort of more or less onto the DSM-5, but it's a sleep specific nosology. And we have insomnias, we have sleep-related breathing disorders with which you'll be familiar. So your obstructive sleep apneas, your central sleep apneas. We have central disorders of hypersomnolence, including things like narcolepsies. We have idiopathic hypersomnia, insufficient sleep syndrome. We have circadian rhythm sleep-wake disorders like a delayed sleep-wake phase disorder or an advanced sleep-wake phase disorder. These are kind of pathologies really that are representative of someone who's an extreme night owl or an extreme lark, extreme morning type, who isn't able to function within the constraints of their kind of work schedule or something like that. We might have free running types who go to sleep later and later every night. Again, a circadian rhythm problem. Parasomnias, things that go bump in the night, sleepwalking. We've got things like, maybe that's quite extreme in some people. Tends not to be a problem in most people. Uh, Confusional arousals, sleep terrors, these kinds of things. And you also see, of course, other parasomnias related to REM sleep. So those are non-REM related parasomnias, but REM sleep behavior disorder, for example, the prodromal sort of symptom or condition that's often seen in alpha-synucleinopathies like Parkinsonism or multisystem atrophy. These are parasomnias that are related to REM sleep. Nightmare disorder, another one. You have sleep-related movement disorders, things like restless leg syndrome, periodic movement disorder, rhythmic movement disorder, sleep-related rhythmic movement disorder. So these are just trying to kind of illustrate how broad the spectrum is of sleep disorders. Sometimes I get these emails from people or letters from people that say that the patient has sleep disorder as if it's a single thing. And actually, what this represents is a really wide range of different symptoms and etiologies. But we're talking specifically about insomnia today, which, as Ian has already said, is the most common problem that we see. So insomnia disorder as a diagnosis represents difficulty falling asleep, staying asleep, or waking too early. That's happening regularly, so 3 nights a week, happening chronically, at least 3 months, and it's something that's affecting daytime function in some way. So that might be in terms of mood, productivity, fatigue, and sleepiness, although typically it's more fatigue than sleepiness. And it may be also that people are struggling with things like their ability to um, concentrate or in other things. The list really is kind of endless, and it's dependent on the individual really making sense of how this is affecting them. It's probably something that affects 1 in 10 adults in the UK, which is a really high prevalence, but probably much more common at a subdiagnostic level, at a syndromal level. So something like experiencing this 1 night a week, or perhaps it not having been met 3 kind of months chronicity. Sleepio is, as we'll talk about in a bit, helpful for both of these groups of people, but that's kind of what we're looking at as a diagnosis. So insomnia development into a chronic problem is something that tends to happen, and this is one of many models that we use to describe the development of insomnia. We're doing so here through the 3 Ps. So we use 3 Ps a lot in modeling. This is a stress diathesis stress model, but we start with predisposing factors. So the individual being predisposed to insomnia might have something to do with their genetics. It's a heritable condition to a large degree. Demographic risks. We all have one characteristic that makes us predisposed to insomnia, and that's that we are mammals, and that's something that predisposes us to not being able to sleep in the presence of threat. There might be something that happens to trigger a period of acute sleep, and that might be a social stressor like job loss or a relationship breakdown. It could be a period of exam stress, it could be a period of illness, but something happens that pushes sleep over this arbitrary threshold. Someone develops a problem with their sleep in an acute sense. And what then happens is, for most people, the acute stressor subsides, people go back to normal again. That phew, got away with it, we're okay. But for some people, and again, it's this 10% that we spoke about earlier, changes to the way they think and feel about sleep, i.e. cognitive changes, and changes to the things they do in relation to their sleep, i.e. behavioral changes, tend to keep the problem stuck. And these are what we call the perpetuating factors that are the targets for treatment when it comes to thinking about CBT for insomnia. So examples of these might be thinking more about your sleep, becoming more worried about it. If you think about, if you're a good sleeper, good sleepers tend not to care about their sleep. They're blasé about it. They don't really mind. In fact, they'll stay up later to watch telly, or they'll, go out for a drink even though they know they're tired. They're blasé. But people who are worried about their sleep tend to think a lot about it, to get worried about it, understandably. They may try hard to sleep in a cognitive sense, but they might also do things like go to bed earlier, lie in the morning, try and catch up on sleep. They might give up on social engagements because they can't face going out when they're feeling sleepy, and so on and so forth. So you can see how these things keep the sleep problem in play. And this is kind of what we're targeting when it comes to CBT. So I'll talk a little bit about CBT, and it's worth mentioning that this is CBT for insomnia is not CBT by any other name. So you come across CBT for anxiety and depression, you come across CBT for other mental health problems, And this is a CBT is a broad approach rather than a unidimensional treatment. And that's kind of important to bear in mind. So CBT for insomnia, or CBTI as it's often known, is recommended as a first-line treatment for insomnia. It's something that we see in the guidance in the UK through NICE, but we also see it in the international guidelines from Europe, from America. And it works on tackling the perpetuating factors that keep the problem stuck. So we have cognitive strategies to work on things like hyperarousal, on sleep-related anxiety, getting unhelpful thinking patterns, things like that. Behavioral strategies to work on sleep inhibitory behaviors like extending time in bed, or going to opting out of social situations, or various other behaviors that might be what we call sleep inhibitory or unhelpful behaviors. There are relaxation techniques again to work on hyperarousal, and there are lots of other sort of more sort of wider ranging techniques that are often included in a CBT for insomnia repertoire. I'm going to hand over briefly to Ian to talk through this.
Thanks, Dimitri. And I think one thing that's important to bear in mind before I set the scene on what practices look like for many years is, whilst cognitive behavioral therapy for insomnia has been a tried and tested treatment of recommendation for decades now, the reality is most of the psychological therapy services and providers do not have the specialist training in the postgraduate training, often in sleep medicine, to deliver it. So our psychological services locally don't actually have any of our therapists trained in delivery of CBT for insomnia. And as a consequence, really, we've left with a gap which for a very long time we've tried to fill, or lent onto medications to fill for our patients. This is a report back in 2021, the prescription medicine dependence form from the Scottish government. And just to be really clear, the statistics are exactly the same for England's government too. I want to make sure we localised it to you, but we're just as we perform just in the same way. But you can see on here the scale of the problem. So 1/30th of the population are on Z drugs medicines across Scotland and across England, and that is a high enough number in itself, but that doesn't account also for significant volume, which we'll be aware of the off-license prescribing as well here, the antihistamines, the atypical antipsychotics, the antidepressants, which we use in different populations for when Z drugs aren't either appropriate or we're trying to tackle other symptoms at the same time. So it's an enormous problem we've found ourselves in with overprescribing. Not only that, but despite the guidance being very clear on short courses only, if you look at the bottom left there, almost 80% of the prescriptions for Z drugs, patients are on them for more than 3 months. The guidance is very clear for Z drugs in particular, they're not more than a week or two at most in most instances, but 80% of patients are in 3 months, and I think 40% of patients are over a year once they start on them. These are really quite startling statistics. Unfortunately, on the right-hand side, the inequalities are all too familiar as well. So the problem has a stark gender divide, 1.5 times higher in females. Worsens with deprivations, where we have higher prescribing rates, and it also increases in prevalence with older populations too. What's a worry here in particular is that these are often the more vulnerable patients that we help manage well, and these medications, hypnotics, can have far more dangerous repercussions for them. So we know for many reasons, and the most stark of which is the lack of access to CBT for insomnia across most services. And we've been overprescribing in this space for a long time. And the drugs that we do are potentially dangerous and addictive. And the reality is that up until now, we've had very little else to offer our patients. If we take to the next slide, Dimitri, the report closes on a high in many places. And one in particular I want to call out is the use of digital therapies, which we're going to get onto in a moment. But they do recognize that digital therapies here are part of the scalable solution to meet the need of the problem which we've just seen on that previous slide. And you can see there about the computerized CBT program. That's what I'm going to touch on the success of that in about 4 or 5 slides time, but it's where they started to use digital therapies which have the ability to scale like a medicine, but not with any of the unwanted side effects and addiction. Slide for me. And really, that was a 2021 report. I wanted to make it just as current as we can do. And the quality prescribing guide in 2024-2027 for benzos and Z drugs also calls out the possibility that could non-pharmacological treatments start to offset some of the change we need to make with effective prescribing in this space too. And so this here where we introduce Sleepio. Now, I hope that many of you will be familiar with Sleepio. But Sleepio provides access to this first line care, cognitive behavioral therapy for insomnia, in a fully automated, fully digital, and personalized way. How it works is patients will log on to it ideally once a day and they'll record their sleep diary. And this forms the basis of the personalized treatment throughout the rest of the program. And then once a week, it then teaches patients these tried and tested techniques that Dimitri will cover for us in a minute, which are heavily evidence based in cognitive behavioral therapy for insomnia. And it does so, as you'd expect, in an engaging and informative way. Patients are then guided through these techniques and have ongoing access to work on these techniques throughout the week as they're entering their sleep diary. Now, because it's fully automated, we'll pop back for one slide. Sorry, Dimitri, I knew that we'd get a driving problem at some point. Because it's fully automated and digital, there are no waiting times. So your patients can get going at a time and place that suits them and at their own convenience. There's no requirement to take time out of work, time out of caring for the family. They can just do it in a time and place that suits them. It's entirely safe, it's effective, and it can deliver treatment to millions of patients at once if it needs to, which, as we've heard from Dimitri earlier, with a statistics of 10% of the population at a minimum, you can see why we need to have that degree of scalability. Finally, next slide, please, Dimitri. And hopefully you're also aware that it's highly evidence-based. So to date, it has 15 randomized control trials supporting it. We've worked with the leading UK and US organizations to gather this evidence. And we actually just had our 100th study published of our digital treatments this week, but there's 15 RCTs through Sleepio. And as such, it, as a world first, it became, and actually is still, the only digital treatment which has a positive NICE recommendations. That was back in 2022 when NICE recommended it as a clinically effective and cost-saving intervention for the NHS when compared to treatment as usual. And these effects have been validated in very diverse cohorts, so across the age ranges, across deprivation indices and genders, and in those with some of the leading comorbidities that we mentioned earlier. And if I'm honest, a lot of that data around the diversity and its effects in diverse populations came from real world evidence in Scotland, which I'll come to in a minute, and you should be very proud of it. We certainly are. Dimitri, do you want to run through the kind of sessions that patients were experienced with Sleepio?
Thanks, Ian. Apologies for the driving problems, folks. I'm trying to do my best. So what's important to understand is that Sleepio is an approach that tries to mimic as much as it can sort of what you might experience if you were seeing a sort of a therapist for CBT. So what we have is a stepped approach across 6 weeks, which, as Ian was saying, is delivered in short sessions that people are able to schedule and do when it's convenient for them. And we start with really formulation, goal setting, diary keeping. The idea here is to get people set up for using this longer term. Although there are 6 sessions that take place, people can use the treatment for up to a year. And so what we expect is that these are the things that set things in motion, and then, as I'll talk about in a second, the treatment kind of carries on through using the diary as a means of then giving the information to Sleepio to then titrate the sleep window and give advice as you go on. So we move then into week 2, and in week 2 we're introducing some active treatments already. So progressive muscle relaxation, which has been a treatment for insomnia since the 1930s. It's effective, evidence-based. It's fairly straightforward. It's something people can actively do to manage their arousal. We introduce some cognitive techniques through thought checking, and of course we start talking about sleep hygiene. Now, sleep hygiene isn't in itself a treatment for insomnia, but it often forms a part of a wider approach within CBT. The third week looks at stimulus control and sleep restriction, and these are the sort of heavy-hitting behavioral treatments that tend to form the mainstay of CBTI in clinical practice. So stimulus control really looks at trying to help people reassociate getting into bed with falling asleep. Very often, people with insomnia will note that they're feeling sleepy, they get into bed and bing, they're awake again, unable to get to sleep. They may spend long periods of time in bed not sleeping, which of course starts to degrade the association that they have between being in bed and being asleep. And stimulus control does a great job of helping to essentially to redress that balance. Sleep restriction, however, and these often work together, these two techniques, but sleep restriction is about really working on in a kind of multifactorial way, but by removing excess time spent in bed. Stimulus control does something similar, which is why they work well together. But sleep restriction involves acutely restricting the time in bed that someone is having on a nightly basis to what they actually need in terms of their sleep. So to begin with, you have a baseline estimation of average sleep across the week, and let's say it's 6 hours on average. 7 hours first night, 5 hours next night, etc., etc. Add it up, divided by 7, you have an average sleep across the week. Now, what you do then is sleep restriction will restrict the time in bed to that average, and then it will titrate week to week the sleep window, increasing it or decreasing it or adjusting it in line with what's known as the sleep efficiency of the individual. The sleep efficiency refers to the amount of time they're in bed actually spent sleeping. So if they're in bed for 10 hours but sleep for only 6 of those hours, that's 60% sleep efficiency. It's not great. If you're in bed for 10 hours, you sleep for 9.5 of those hours, that's 95% sleep efficiency. That's much better. So, of course, sleeping for 10 hours in an adult is kind of very unlikely, but just to illustrate the point. As you get into weeks 4 and 5, depending on the priorities, so this is again where Sleepio starts to tailor itself to the needs of the individual. We may introduce more cognitive techniques like cognitive restructuring or thought challenging, autogenic training, imagery practices, mindfulness practices, and things like paradoxical intention. Again, all of these are evidence-based approaches, and in themselves, these treatments are useful too, but they're used in combination here to maximize their utility. We get on to week 6, and in week 6, we're reviewing the goals, we're reinforcing the motivation to carry on. And as the patient then carries on through using the program, they're using the sleep diary, they can continue, sleep restriction continues to work. They can go back, continue to titrate the sleep window, but they can also go back and look at these old sessions that they've been through and then refresh their memory, dip into other content on the program, and then continue to use the program going forward. So it's not just that you kind of get 6 sessions and that's it. It's a longer term approach. Over to you, Ian.
Thanks, Dimitri. So now to shine a bit of a spotlight on Scottish Government's commitment in this space. So back in 2021, Scottish Government partnered with Big Health to bring actually 2 of our treatments, both Sleepio and Daylight. And Daylight is our treatment, very similar concept to what you've heard for Sleepio, but for anxiety. Partnered with Big Health to provide both of those treatments at scale to all adults for free on the NHS in Scotland. Sleepio can be accessed, doesn't need a referral, it doesn't need a prescription. And for that reason, we have both what we call guided and direct access channels. So guided is simply being signposted towards it by a clinician or by a clinical team or practice. And direct access is, as you'd expect, people finding out about it online. We've had radio ads, there's been ads on Tube. Scottish Government has spoken about it in many forums. And so patients can access it in either forum. We have really good coverage across all 14 areas across Scotland. And the uptake was certainly very quick to start off with all areas having good uptake in the first 3 months. Also then very proud to say the last 3 years that we've now had over 85,000 patients go through the Sleepio program in Scotland. That's as many patients as we've had through the traditional psychological services in Scotland in that same period. So it really has had a huge impact on the provision of mental health services across Scotland. So much so that actually the First Minister last month mentioned the success of this computerized CBT program in his address. I think the last bullet point is one where I think we could do so much better. And actually, the vast majority of the patients we see coming through actually are guided there through the psychological services teams, which is no surprise because that's where the commission was first made. But you and I will know that the general practice is where and community pharmacy, those 2 areas are where many of our patients are first presenting with either the symptoms of the consequences of or directly with presentations of insomnia. So we're very keen to work more with teams in general practice. And much as in the same way we're doing this training here this evening, if any of you would like to have training for you in your practice, bearing in mind it doesn't need to be a clinician that can signpost patients to this. We've worked with social prescribers, we've worked with, as I mentioned, community pharmacists, mental wellbeing practitioners. We're very happy to come even at a practice level and do 10-15-minute upskillers for your staff too. We'll leave our email address at the end and you can let us know. But I suppose this slide, to summarise it, it's the programme so far has been a rip-roaring success, and Scotland really is the crown of the world of delivering digital CBT for insomnia, which we're very proud And so how can you offer it to your patients if you do speak to your patients? We keep it as simple as possible, and the Scottish Government help us keep it as simple as possible. So it's currently only licensed for those over 18 and over. And patients don't have to have full diagnostic insomnia, as Dimitri mentioned earlier. They can just be struggling with poor sleep, and the program itself will guide them through whether it's suitable for them or not, whether they're better going back to speak to a clinician. And we don't do that lightly, but for certain indications, so if it's strongly suggestive of, for example, obstructive sleep apnea, it will signpost someone back to see a clinician. So as long as they're over 18 and are having some difficulty with their sleep, they need to be able to understand conversational English. We do have a Spanish, I think it has actually just landed, so Spanish or English, but they need to have access to the internet as well. And we do often try to say to people, if you are signposting them there, try and let them know that the more they stick with the program, the more they will get through it. As with any treatment compliance, just doing one session for 10 minutes, you're not going to get the full response. It's the same with physiotherapy, being taught how to do an exercise in one session, you've got to put the hard work in afterwards. So you do have to commit to doing a reasonable amount of the program to see the benefit. And it's as simple as them going to sleepio.com/NHS, and they'll be guided to onboard onto a program. That's all you need to be able to offer your patients. So you can send it in a text message from your surgery. You can put it in leaflets. We have leaflets we can send to you if you'd like, and digital resources too for your waiting room or for your practice website. All your patients have to do is go to sleepio.com/NHS. People often ask, how can I explain it to my patients in 30 seconds? Because that's often all we have as we've come to the end of our 10-minute consultations. So simply, I keep it as the what, the why, and the how. So what is Sleepio? It's a nice recommended treatment for insomnia and poor sleep. Why should we do it? Well, it delivers a clinically proven first-line treatment, CBT, in 10-minute sessions over a 6-week period. Great. How do I get started? Go to sleepio.com/NHS. And that's all. We kept it intentionally brief. I know the session was scheduled for an hour and a half. We always like to leave a lot of time for questions. I'm very happy to take any of those questions you want to pose to us. There's a few in the chat already we can work through. Equally, Dimitri, if we keep that slide back on for a minute, the email address there is at the bottom, which I think, there we are, nhs@sleepio.com. Any questions, any requests for resources, materials, training, or to continue the conversation, please do just drop us an email. We're a small team here in the UK. They will come through to me, and I'm very happy to pick them up with any of you individually. I've just seen Kirsty come back on camera.
Hello, sorry, I am here. Thank you. Thank you both so much. So yeah, I did see some bits in the chat there. If anyone, has any questions, would they like to come on to camera and ask them, or feel free to use the chat bar. You can keep using that and we can go through them. So anyone got any questions at all? I don't see any hands going up. Oh, there's one in the chat, I think.
A couple in the chat there. Yeah.
Should we start in the chat and give people a chance to give a
Let's start in the chat. Are you happy to go through them just from the top? We've got the first one about
Yep.
Can you see them okay?
We can see them. We'll take them as they come. So
yeah, perfect.
the first one I'm sure everyone can see, but the first one's from Kit, and it says, I work in an area of England where Sleepio still isn't available, which is frustrating given the lack of free alternative. Do you have an idea of when the wider rollout can be expected?
Yeah, I'm happy to take that question. So, yes, because it's very frustrating. Everything that we have, I'm going to call it a postcode lottery, but a Hadrian's Wall lottery of access to Sleepio. Scotland, 3 years now, have had access where England haven't, apart from a few regions. There was a national tender open last year for a digital CBT solution for insomnia, but unfortunately we've had a change of government and a budgetary reset since then. But we're very hopeful that we'll come to an agreement to have similar access across England as patients do have in Scotland very soon. And if you either drop me an email, or if you like, I can actually, yes, probably drop me an email, get on that email address, and I can let you know as soon as it's available for your patients.
So another question about how easy the app is to use, especially some of the patients we see are elderly and not tech savvy. I think we get this from time to time, don't we, this question? And I think what's really interesting is that the data we have don't really suggest that that's necessarily such a problem. So it's interesting that I had the same assumption myself, but actually it's something that is very straightforward to use. It's very user friendly. And yes, you might have people who struggle a little bit with accessing tech or using tech. In our experience, once you're able to access it, once you're able to use it um, through a device, then it's fairly straightforward to use. So maybe the first bit is a hurdle that doesn't necessarily relate to sleep. It maybe relates to uh, having a smartphone, being able to use it, and that kind of thing. But once you're there, once you're using it, then it is fairly straightforward.
Yeah, I'd certainly echo that. And there was a report a few days ago actually on the BBC around um, actually that the misconceptions around all the populations being able to use digital interventions is largely being is disproven.
Mm.
Dimitri's right in the evidence, but also personally, anecdotally, from
Mm.
myself, I've had patients way into their 80s use the program with good success. We've had some wonderful case studies as well in Scotland where patients who actually don't have access to a smartphone or to a computer have come together at community centres and they've done it as a group, five or six people with a social prescriber going through the program together in a group, which is not how we'd recommend it, but it worked well for that group who didn't have the digital devices to do so. But we're finding more and more um, innovative ways of delivering Sleepio sprouting up across Scotland quite regularly, which is good to see.
Mm. Is there another?
Yeah, sorry, on you
You
go.
go
No,
ahead.
I was
You
just
go
going to
ahead.
say
You go ahead, Kirsty.
the next one's not really a question, but somebody who's used Sleepio for their own insomnia, just, saying it was fantastic, made a massive difference within a few weeks and has lasted, very easy and appealing to use. So that answers that question before there as well.
Great. Really pleased to hear it. Thanks for sharing. And the other thing to bear in mind is that you can try it as a clinician. You needn't have insomnia to try it and give it a go and have a look and see and try before you, you recommend, as it were. So that's an option for everyone. So another question. Oh, they keep changing. Going up. What training do we need to prescribe guide patients to it? Well, you don't need anything more than what we've been through today, to be honest. But we're very happy to provide more should you wish. Uh, is that available online or is it on the app? We do have online training available too that we can refer you to. But the reality is it's as simple as what we've just discussed. And so you've got that on the recording of the session we have today anyway.
And also, it's important to mention the program will onboard patients as well, so it doesn't dive them straight into full-blown cognitive techniques. There's an introduction, there's an engaging sort of video content to get people, anyone from a reading age of 9 upwards, to get brought into why they're there, what the solution will do for them, if it's the right solution for them, and introduces the techniques in a very gentle and engaging way. So to answer that, very little guidance and training is needed to provide with patients. But if you can offer them anything about why this is the right treatment for them, for the kind of information you've heard this evening, we know that it helps with their engagement with the program.
It really does. So having a doctor or a whomever it might be, a clinician or a non-clinician who's recommending this because there's a rationale for doing so, that sharing that rationale is very important, and having an engaged clinician who can see the value of it, I think is going to increase the likelihood of the patient engaging with things. Where are we? So is it available in England as well? In some areas of England it is. We've spoken to that already, I think, that question, but not everywhere. Watch this space. What do you do for children under the age of 16 with insomnia? So I've just finished my clinic today at the John Radcliffe in Oxford, seeing pediatric patients today with sleep problems, and lots and lots of young people struggle with their sleep. And I think it's really important to understand that it's really, really very varied. The kind of problems that we might see clinically, we might see things that relate more to circadian rhythm change. So you might see people, for example, today I saw someone today, for example, who's typically developing, falls asleep at about 2 in the morning, but is unable to wake for school. So will fall asleep at 2, when left to sleep, will wake at probably something like, I think it was about 10 or something like that, 10 or 11 on the weekends, and sleeps very well, no problems at all. When left to sleep in, does fine. But of course, when woken for school at whatever it is, 6:30 or 7, is going on a third less sleep per night than they would otherwise have. And of course, that's crippling over time. So it's chronic sleep deprivation, really. So they will struggle with their mood, they'll struggle with concentration, they may have neurobehavioral symptoms that start to emerge. But these are all because they're not getting what they need from their sleep. And that is by and large a normal change that you see in adolescence. It's someone who's becoming a night owl, delaying is what we call a delayed sleep-wake phase. That is an insomnia. It looks like insomnia, but it's not insomnia. It's a circadian kind of issue. And that's something that probably needs to be managed in a very specific way. I can talk more about that later if people are interested. But in terms of insomnia, what we tend to see in younger children can be broken down into kind of various subtypes. So the first subtype is what we call sleep onset association problems, and these are often problems typically with much younger children, where they require parental presence to fall asleep. So they may be getting into bed and they need their mum or dad there or carer there to allow them to fall asleep. Otherwise, they'll call out for their parents, they'll have the parent come back in. And in very, very young children, we recommend uh, behavioral techniques for managing this. As people get a bit older, it's a bit more tricky. But that's something that is the first line evidence-based approaches, the guideline approaches here are behavioral treatments. Where you have children with this is probably what you're likely to see in general practice quite a lot too, children with suspected neurodevelopmental disorders or who have neurodevelopmental diagnoses. We still recommend behavioral treatment in the first instance, but it may be the case that eventually melatonin may be considered too. There is a specific indication for a particular preparation of melatonin in relation to children with autism, not with children with ADHD, but with autism. And that's, of course, something that you can follow elsewhere. I won't be talking about that too much today. But I just want to kind of highlight how variable sleep disorders can be, and what looks like insomnia isn't always necessarily insomnia in the way in which it might seem. It could be a symptom of something else. Restless leg syndrome, for example, being put to bed too early. So you have a case this morning of a young person who's put to bed at 8, but doesn't fall asleep until 9:30. They just don't do that. So being put to bed at 8 every night for years and years and years has resulted in them developing now, and I can't fall asleep. I just can't do it. They can't do it because it's a circadian mediated thing, right? They can't do it because their clock's not in the right place. But that's not an insomnia problem. And over time, they've developed a kind of an insomnia in relation to being put to bed too early. So the piece of advice there is put the child to bed a little bit later and then work your way back. And that's kind of often helpful. So again, what I'm trying to demonstrate here is the variety of things you might see. But they of course, yeah, these are things that will need to be treated in the kind of right way. I could go on for a long time, but Ian won't forgive me. So
Let's jump to the next question. If people have more questions,
jump to that question.
pediatric insomnia, we can come back to it. Should we direct people directly to sleepy, or do you have immediate suggestions you should start patients with? You can some people straight away. As I mentioned, there's a very gentle onboarding process, an engaging onboarding process that the program itself takes it through, and that really is designed to make sure that you don't have to have any expertise in insomnia and sleep medicine to recommend these treatments to patients. However, we do have, as I mentioned earlier, we have some physical print resources we can send out to your practice to have on the desk, or you can have some of the digital ones and these leaflets and one pages will introduce the treatment to patients before they get onto the program itself. And again, very happy to send those out to you physically in the practice. Just let me know. From Nadine, any advice about daridorexant? Actually, we've got two questions on that. I think two down as well. Your thoughts on daridorexant, having prescribed it for patients who unfortunately didn't gain benefit from CBTI, and how long it can be used for. Dimitri, you've probably got more experience of this than I have, but I can talk to it as well from a general practice perspective.
Sure. I mean, so the indication here is insomnia where CBTI hasn't been effective, or insomnia where CBTI isn't available. And so it's a second line treatment where you have these specific indications. For me, in my experience, I certainly have met patients for whom CBTI hasn't worked, and we know that there's a group of probably about maybe as much as 30% of patients for whom CBTI might not be helpful. Like with any treatment approach, that's just the way it is. 30% is actually doing pretty well if you think about treatment response of 70% of the people given this approach. But the reality is that the main problem we have is access to appropriate treatment. Digoxin, kind of in terms of prescribing how long you should prescribe it for, I can only really, given the kind of limitations of what we're talking about today, I can only really recommend you follow the guidelines that are available through NICE. You should expect some degree of improvement, I think, within a couple of months. I think if you look at the guidelines, but again, I won't speak to the specifics of prescribing digoxin today. Ian, do you want to talk a little bit more about it?
Yeah, so it's slowly getting more uptake across the different formularies, certainly in England anyway. And as you mentioned, and as Dean, you mentioned in your point there, it is indicated when patients have tried and not been successful with CBT for insomnia, or where it's not available, which is a pain point for us in England.
Yeah.
And undoubtedly drugs have their place in the
Yeah.
therapeutic pathway for insomnia. What I will say is that we find that there is only one way currently that people can get to the root cause often of insomnia, and that is tried and tested, proven CBT for insomnia. So we know that's the treatment that internationally the guidelines all recommend, and so really just encourage your patients to give it as good a try as possible before they move on to second and third line treatments.
It's also worth thinking about things again through a step care lens too, right? So people with CBT, if we think about CBT through a step care model, Sleepio provides things at quite a relatively rudimentary level in many respects. It's right at the bottom of the step care pyramid. But what we're looking at in terms of CBT can be accessed higher up too, so that you can always step people up where it is available in person-to-person, face-to-face thing. I gave a lecture several years ago about at the Royal Society of Medicine about what to do when CBT for insomnia doesn't work. And to the surprise of many of the attendees, my response was, well, try CBTI again. Because actually often the case is that it might not have been tried in the right way for the individual. Or various other things. So the fact is that, yes, of course, there are these second line treatments and they're there and they to be used in line with their indications. But at the same time, we have to think about CBTI as being a little bit more than just one thing. It's a broad treatment approach, and it's often sort of all too easy to say, well, it didn't work, but we don't really maybe know why it didn't work. Was it offered in the right way? Was it explained correctly? Did the person engage with it? Did they try it, etc., etc.? So there's lots of reasons why we might want to reconsider the CBT in the first instance.
I think to double back on one of the questions we had earlier about older populations as well, many of the guidelines now, both with the Beers criteria and American Geriatric Society, as well as the British Geriatric Society, are starting to recognise the particular dangers that hypnotic agents of any kind pose to people over the age of 65. And the guidance now are actually relatively clear that you don't prescribe in those populations, apart from very exceptional circumstances. And even things like the new agents like daridorexant, actually, if you look at the NICE guidance, it's clear around there's a lack of evidence supporting the safety profile in that group. So they also caution people away from it. Insomnia as a diagnosis is most prevalent in those older populations, and so we really have to start practicing and getting used to the language and description of non-pharmacological treatments for those groups in particular, because we know the impact is not so much of addiction dependence, but is of falls, fracture risks, polypharmacy, and comorbidities, which is all the more significant in those groups. So just tying those questions together, I suppose. Liana, apologies, because I think I didn't make this clear earlier, because you've asked a very sensible question, which is thinking about sleep hygiene and use of screens around bedtime. Is there any other way to just kind of CBT? It's a great question, because if CPO is taken effectively, if you like, it shouldn't be doing CPO at night, midnight, when you're trying to get off to sleep, desperately tossing and turning in bed. No, they should treat it like any learning program. They should do it ideally when they're most alert, when they've got a time and space to focus on the activities and the interventions themselves. So 10, 11 in the morning, they can spare the time or time around, away from work, away from distractions of day-to-day life, and that accompany that. That's when they should focus on these treatments. Now, they do have in the program, if someone is struggling in the moment late at night, there are some on-demand tools that they can use in the platform. Yes, not ideal that it's from a blue screen device, but it will offer tips on relaxation and de-escalation of their raised arousal. So there is that in-demand moment, but the majority of treatment should definitely be done away from bedtime, away from the bed itself, at a time when they can consume the information in their most optimum way.
I might be a bit risque here and say, don't worry too much about the blue light. Blue light it has it has an effect, but even sort of it's something that we sometimes over egg a little bit in terms of the emphasis. Mainly when it comes to devices, these things are designed to be very addictive. They're designed to make you want to use them more. That's kind of the way in which the apps and things are designed. The content of the app, the way you're using it tends to be something that's slightly more problematic. Light itself, if you turn the light down, if you turn the brightness down, if you use these filters and things, that kind of takes the edge off. You're not doing it all the time. Bright light as a stimulus, if you're giving that bright light to someone just before they fall asleep, a kind of normal time falling asleep, it's not going to have a huge effect. It might kind of delay sleep a little bit, but not by a huge amount. If you're using it every night in the same way, very close to the eye, and you're doing it at the right time in relation to the phase response curve of light, from a circadian perspective, it will have an effect, but it's not as bad. So I tend to, much prefer people feel kind of easy breezy about it and not get worried about it and get caught up in it. And as Ian say, do it during the day, relax, try and get rid of your phone at night anyway. It's not helpful, but having access to those, break glass if in need kind of things, that's great. That's great to have access to too, but use them sparingly, I guess. So another question about direction and then also about England.
Question here, probably in your realm here, Dimitri. So if a patient is waking up at 3 a.m. every morning, increasingly tired during the day,
Yeah.
doesn't want to go to bed early, as wants to have family time, and sleep isn't available, what else can be done?
Yeah, so it's a great question. So if the patient's waking up at 3 a.m. every morning, and it really is every morning, and it's not 3 a.m. some mornings, 7 a.m. some mornings, 2 a.m. some mornings, but it's very consistently early, then that might be, and they're very sleepy in the evening and able to fall asleep easily in the evening, then that's symptomatic of something we might call an advanced sleep-wake phase. In this case, it's an advanced sleep-wake phase disorder. It's something that's causing a problem for them. So an advanced sleep-wake phase disorder refers to someone being a morning type and a lark. And this is something that would be, if it's very, very consistent in that fashion, means that their sleep window opens early and it closes early. But if they go to sleep early, they get enough sleep when they wake up early. That's the key thing, that the window allows for sufficient sleep to take place. If, however, they're unable to fall asleep until 11 and then wake up at 3, that's slightly different. And that might be more symptomatic of insomnia in the context of something like depression or various other difficulties. And it's less likely to be so consistent in that regard. So what we tend to do with people who are waking up very early is you can use bright light in the evening. What? Bright light in the evening to move the clock later. Or you can use melatonin in the morning to move the clock later too. And these are things that they're in the domain of sleep medicine. So they're things that we would do in a sleep medicine service. It's not the kinds of stuff that routinely people would do in general practice, and it'd be tricky perhaps to do it. But there are treatments you can do. So one of the things you can do is if you feel like you're unable to do it within the sort of limitations of 10-minute consultation, is to refer someone to a sleep medicine specialist. And there are sleep medicine clinics around with the suspicion of it being an advanced sleep-wake phase disorder. But not wanting to go to bed early and to have some family time is very reasonable, because he wants to enjoy his life. So doing something about it is helpful. Evening bright light through something like this. That's what's known as a light box or a sad lamp. Typically they're marketed as, but bright light in the evening. Maybe if he's falling asleep, relatively early, you kind of push it by giving that bright light maybe at around it, and then 3 a.m., maybe 9 o'clock, something like that. Difficult to say without a proper workup. But the idea is that pushes sleep away. Light has the effect of pushing sleep later if you give it in the evening. And melatonin in the morning is given at a subhypnotic dose of 0.5 milligrams, 0.2 to 0.5 milligrams. And that given in the morning, typically 6 hours after the sleep midpoint, has the effect of being able to shift sleep um, uh, later. And that's something that is to do with the circadian mechanics of the phase response curves of light and melatonin respectively. But fear not, Professor Colin Espy is going to give a talk on managing sleep problems in general practice a little bit later on this month, I think. So you can ask him too, and he might be able to tell you a bit more about it. So I hope that's helpful. But yeah, great
Thanks.
question.
A few more questions here, and if there are any more, please do drop them in. Is this CBTI recommended for all patients with insomnia, i.e. patients with anxiety or depression can still try it to help sleeping?
Yeah, absolutely. Patients with, I mean, patients with insomnia tend not to have insomnia by itself. It's the pure insomnia that people can sometimes refer to is something I don't see very often. And most people with insomnia that I see will have low mood, or they'll have anxiety, or they'll have another comorbidity of something, as Ian mentioned earlier. So absolutely, and it's the guidelines suggest, or when we think about insomnia, insomnia should be treated wherever it presents. So if it presents, by itself, great, treat insomnia. If it happens to present comorbidly, we treat insomnia. Where people have insomnia alongside something like depression, in the past we used to treat the depression in the hope that the insomnia would improve and just sort of spontaneously remit. What we know now is that there's a complex bidirectional relationship between sleep and mental health, things like anxiety, depression. And so actually there are trials now that show treating, when people have insomnia and depression, treating just the insomnia actually improves the insomnia and the depression. If you treat just the depression, you seem to improve the depression perhaps somewhat, but you don't manage to change the insomnia. And the fact that the insomnia is still there increases the risk of relapse of depression. So it's kind of bang for your buck if you think about it in those terms to provide CBTI for people where those problems exist comorbidly.
We actually had a study published about 2 weeks ago now. It wasn't one of our studies, but an external organization who was using Sleepio in patients with significant depression, and it was found to be significant, and it improved their depression just using the Sleepio program as well. So not just for CBTI, but also for the digital CBT programs which we've spoken about today. Two questions. I'll take the first one, which is the cost of Sleepio app privately if patients don't have access via the NHS. We don't have a means for private or self-pay of the products, and never will. We don't want to create a health inequality whereby those who can afford to pay for treatment can access it. And so we don't technically have the ability to do so. If, as a clinician, and you're in Scotland, you can obviously try the solution yourself, or your patients can. If in England you're a clinician and you want to see what the program looks like, again, drop me an email and I can send you an access code, or one of access code, so you can look at the solution yourself. But we don't have the ability for you to pay for yourself, or for patients to pay for themselves either. Two more questions. When to consider melatonin in patients with insomnia, Dimitri?
Well, so there is an indication for melatonin in adults over the age of 55, I think it is, with insomnia. I think that's in the guidelines. But the reality is that most people with insomnia, you kind of need to start again with, as I say, first line with CBTI. Melatonin, as we use it in sleep medicine, we tend to use it more as what we call a chronobiotic, as a circadian sort of modulator, really. So we use it to push the sleep-wake phase forward or backward, and we do that by administering it at a very particular time in relation to the patient's sleep-wake phase, the circadian profile, and we do that typically as a subhypnotic dose. So we're not trying to get them off to sleep, and we move it in that way. Where it's used as a hypnotic, remember melatonin has a very mild hypnotic effect. It's sort of a little bit analogous to something like, I don't know, a low dose of promethazine or something. So it's something that gives you a bit of a drowsy sensation, but it's not something that might it's not something that's going to be sort of heavy hitting like zopiclone. So again, just advice is always just follow the guidelines available through NICE. But yeah, when it comes to melatonin, there are specific indications, as I say, kind of for people over the age of 55 with insomnia, for in particular preparations for children with autism. Yeah, so that's the kind of, without kind of going into the idiosyncrasies of separate kind of groups.
A question here for Rosie around we know programs like Silver Cloud are helpful for insomnia.
Yeah, so I don't know very much about Silver Cloud, to be honest. So I can't sort of speak to it really. But what we certainly can do, I think they do have CBTI through it. Ian, you probably know more about it, so perhaps
Yeah,
you
they have a Silver Cloud for all insomnia. I think it's a one-off sleep module on there. I suppose I'm undoubtedly I'm sure it helps. It's most of the programs available for the Silver Cloud product, I believe, are based on good cognitive behavioral therapy techniques. The big caveat that comes alongside that is they haven't yet been tried or evaluated for their evidence base. And you have, if you're in Scotland, you have access to an evidence-based treatment that has been through the rigor that you expect any other treatment in the NHS to go through. And I would encourage all other providers of products like this and Silver Cloud to follow that same route, so you can have an independent assessment about which treatments your patients can have access to. Do I think it's harmful for patients? Certainly not. Do I think it may offer them some support and help if that's what's available? I'm sure it does offer some help. So if that's what you have available locally, I would certainly encourage your patients to try and use it. Manas, sorry, I think I'm not sure when your question came in, so I'm not sure what conversation topic we were talking about, but it would either have been melatonin or daridorexant in response to your question. I don't know if you're able to give us a bit more qualification on that. Yeah, so if you do feel like I'm writing a new question or coming off mute, so we can take your question, but I'm not sure I picked up when that question came in. Are there any more questions either from the floor or in the chat? I'm mindful it is 8:45. We're doing a session on World Sleep Eve. I'm sure people are getting ready to wind
the
down.
sleep.
But it's been a real delight to speak to you all this evening, and thank you so much for welcoming us into your homes tonight. I thank you for Kirsty for organising the event for us. We're always keen to speak to more clinicians. I do mean genuinely. If you want us to come speak to your practice and your colleagues about this, we do training at any size, both practice level and upwards. We spoke with the National Medicines Optimisation Team, NHS Scotland, only 2 weeks ago, and similar excitement amongst the room there for the initiatives too. So thank you very much for
Thanks everybody.